I'm Dr. Bob Krueger, and I want to tell you how much I appreciate the South Texas Geriatric Education Center for inviting me to talk with you today about depression in the elderly. And just to give you a little bit of an idea of where I'm from, I'm Chief of Geriatric Internal Medicine. I'm an internal medicine doctor at Wilford Hall Medical Center, the largest medical center in the Air Force in San Antonio. And I'm one of 2 geriatricians in the Air Force. So real happy to be talking to you about depression in the elderly. Before I start, I just want to talk about 2 other topics just very quickly. Taking care of older people as patients and taking care of older people as people. Older people as patients, they present a challenge, and it's a lot of fun to take care of older people. If you really think about it, the older people that we have right now were born between 1915 and about 1935. This was a generation of folks who did a lot for us, and we owe them a debt of gratitude. They were the generation, the men went off to war and the women stayed home and built the airplanes. And when you take care of older patients, take care of them with excitement, because we really owe them a lot. Taking care of older people as patients can be very rewarding. Now, older people as people, they have a lot of stories to tell, and sometimes when you're not in the doctor's office, it's a little difficult to, it's kind of a lot of fun to talk to older people, to hear the stories that they have. Here's one of them. Here's Grandpa Snake talking to the kids, and he says, "Oh, again? Oh, all right, one warm summer evening many years ago, I was basking on a stretch of Interstate 95 not too far from here." So we can learn from the mistakes of our older people. What I want to talk about, at the end of my talk today, you should be able to understand that depression is common among the elderly. We see it all the time. And it's a bad disease. It causes a lot of morbidity and mortality. We also should be able to appreciate the 3 types of elder depression. And we'll talk about that in a little bit more depth in a few minutes. And the diversity of their presentation. Elder depression takes a lot of different faces. And also, we'll be able to discover the several medications and modalities of treating elder depression. Elder depression is very treatable. Is this one?
Can they hear now?
Can you hear now?
Now we can. Thank you.
Okay.
Thank you.
That sounds fine. All right. So here's an overview of what I'm going to talk about. Elder depression is commonly seen in a primary care practice, but we as doctors often don't recognize it, and because of that, we often can't treat it. So it's real important. It causes a high degree of morbidity and mortality, and it's treatable. So if you see it and recognize it, treat it, and your patients will do well. So the first topic I want to talk about, elder depression, is very common, and it's very, very widespread. Depression overall affects about 1/3 of adults sometime in their life. And at any time, 5%, that's about 1 in 20 of adults, are clinically depressed. More women are depressed than men if you look at a huge population, and more men are more dysthymic than women. And we'll talk about these in a few minutes, what these terms mean. Now, when we look at depression in the elderly, if we're looking at community-dwelling elders, major depression occurs in 1 to 5%, and that's about 1 in 20, but about 20% have significant clinical symptoms of depression. And that's very scary, because it makes people really feel bad. Older people really feel bad from these. You'll see some of those symptoms in a little bit. and it can be very debilitating. Now, if we take a look at nursing home populations, we're talking, the community dwelling elders, but now if you look at a nursing home population, there's major depression in 15 to 25%, 1 in 4 of them, and minor depression in 30% to 50%. So almost half of your older people in nursing homes have some degree of depression or depressive symptoms. A lot of that becomes because of control. If you lose control, a lot of times you feel like nothing, I don't have any control of anything that's going to happen to me, and these people feel bad because of that. Depression has a very substantial negative impact on the elderly as well. Let's talk about the impact of depression. The World Health Organization says that major depression is the 4th leading cause of disability worldwide. That was in 1990. Now, globally, our population is becoming older. In fact, if you look at the United States population, the group over 85 is the fastest growing population, part of our population. So we as a population in the United States are aging. Worldwide, we're doing the same thing. Soon, major depression will be the second most leading cause of disability, second only to heart disease. What's the impact also individually when you look at just people themselves? Well, on older people, they have a decreased functional ability. They can't do the stuff that they want to do. Depressed elders have a reduced quality of life. They have an increased disability and mortality. They don't live as long as another cohort that is not depressed. They use the medical services more often, and the fact that they can't do the things that they need to do, they're more of a burden on their caregiver, on the people who take care of them. This is a very scary statistics, but if you look at suicide in the elderly, they have the highest rate of suicide, and depression is a risk factor for suicide. Among the general population, 12.4 per 100,000 commit suicide. 80 to 84-year-olds, look at that, 26.5, more than twice the rate of suicides in this population group. Very, very scary and very sad. They do the obvious things that you see, but they also do some very subtle ways of committing suicide. If you think maybe a married couple has been living together for 60 years, and then either the husband or the wife pass away. The other one is just left all alone. Very commonly that they very passively commit suicide. I'm not going to eat anymore. I'm not going to take these medicines. I realize I might have bad heart disease, but what's it worth it? Why am I prolonging my life? They might drink alcohol more or take risks doing bad things. So things to look at, and look at your older patients in that regard. Look at them. Have they given up? Two very important disease management concepts for taking care of, or for looking at elder depression. One of them is you need to remember that elder depression is a chronic illness. 30% remain chronically depressed. We can treat it, but when it's identified, you still need to think in the future, gee, could this be depression? Maybe if you identify it and later on down the road the person's getting better, but then they have something bad that happens, you need to think, well, maybe are they becoming depressed, or do they have a tendency of getting depressed? And you might want to jump right on that. Recurrence, very common. We're going to talk about recurrence in a little bit. But it clearly interferes with daily function, and it impacts with other chronic illnesses. Picture this. If you have a patient who might be taking 4 or 5 medications, and they just become depressed, and anything that they do is a chore, they might not take their diabetic medications, or they may say, well, I'm not really going to take my insulin today. That's going to impact on the other chronic diseases. So real important to look at that. So just sort of in summary, right up until this point, depression in an older person is very pervasive, and it can impact a lot on what happens with them. Concept number 2, the data we have on identification and treatment of older patients and depression is based on public health data. So it's based on large groups. But when you treat patients, you don't treat large groups, you treat individuals. So we have this information, but you also have to remember that now, even though the large group says if you put a patient on this medication, it will work for them, remember you're taking care of an individual. So treatment must be very individualized, and there's a lot of different treatment venues that can be used with elder depression. Let's talk about the 3 types of elder depressions. And they sort of become a spectrum. They can start out as a little bit of depression, a little bit more depression, and a whole lot of depression. So major depression is the whole lot of depression. Minor depression, a little bit less, and dysthymia is the sort of the less depression, almost on a spectrum, almost on a continuum, but they all have a little bit different features. Major depression, this is what the DSM-4 says about major depression. 5 or more of these, most days over a 2-week period, but a change of how they are normally. And kind of run down these, and then picture in your own mind, if you're a doctor seeing a patient and they come in and they present with something, one of these, would you think depression? And that's real important. Sleep disturbance. Gee, doc, I can't sleep anymore. Or, yeah, I just don't really want to do the things that I used to do before. Or, I don't have any energy and my concentration's down. I just don't feel like eating, and yeah, I'm losing some weight, or I'm just sort of down. Now, very common for doctors to say, well, maybe it's because you're old. You know, you're older. You're going to slow down, and to try to work it through that way. But think from a depression point of view. If you look at this list and you see any of them that really stands out, if you look at guilt, worthlessness, or self-reproach, if a patient comes to you and they just feel worthless, they say, Doc, I just feel horrible, I just feel like there's nothing left, I'm giving up. That's pretty sensitive identifier for depression. There's not an awful lot that can cause that. If you look at other things, concentration, well, maybe you might have a little dementia or sleep disturbance. There's other things that can cause that. Sort of maybe I don't have any energy. Maybe there's other things that can cause that. Thyroid disease, or even just being in a temporary slump. But if somebody has guilt and worthlessness, think depression. Big, it's real important on that. Now, minor depression, a little bit less depression. It's not the major depression. That's less than 5 of these. So major depression, 5 or more. Diagnosis of minor depression, less than 5, but the same thing. Most days for 2 weeks, and it's a change from how they've done in the past. And the same thing, sleep, interest, guilt. Doctors like to use mnemonics, and if you take a look on the left-hand side, it says STGEC caps with a D in the back. And it kind of means SIG, prescribe ECAPs, energy caps. Just a little bit of a way for you to remember that. Now here's dysthymia. Dysthymia looks a little different. That's a depressed mood. Yeah, I've got the slumps, I'm a little bit down. Most of the day for 2 years. That's like a lifestyle. My lifestyle is to be grumpy. And when we diagnose dysthymia, that's a little different. That's, you know, I've been kind of grumpy for 1.5 years. Well, you haven't fulfilled the criteria yet, so should we treat you or not? So kind of thinking that way. No symptom-free period for 2 months. 2 or more of these that occur during periods of depression when you're down, poor appetite, insomnia, low self-esteem, concentration is down, hopelessness. Why is it so difficult to detect depression in the elderly? And I've already touched on this a little bit. Where do they present? This is important to remember. Older people, if they're depressed, they don't go to the psychiatrist. They go to their primary care doc. And they go in the context of physical illness. Doc, I just don't feel good. They don't say, I feel depressed. I think I'm depressed. They say, I have pain. I can't sleep. I have diarrhea or constipation. I have heart palpitations. I'm dizzy. Just, something's going on. So look for somatic complaints on that, on your older people who might be depressed. It's also very variable in older people. Sometimes they look sad, and sometimes they're not sad. Sometimes they're trying to be strong for you, because they don't want to think, well, maybe the context of depression years back was it's a sign of weakness, or it's a sign of mental illness, or it's a sign of, gee, I'm out of control. Maybe they'll put me in a nursing home, something like that. And older people are very scared of that. So look for a really variable presentation. They might be just grumpy, maybe social withdrawal. They don't really want to go on out. Tired, hurt, can't sleep, poor appetite. Those of you who are moms know that when your little ones, if you have little ones or maybe toddlers, a year old, how do you know that they're not doing well? How do you know that they're sick? Well, they don't eat, or they're irritable, or they're grumpy, or something like that. It's the same thing. Moms can pick up having their child sick a lot sooner than doctors can, so very sensitive. So just kind of look for those in your older people. Here's the diagnostic dilemma that we all face, and the doctors face a lot too. We often think it's a normal part of aging. You're getting old. It's okay for you to slow down. So before you think about that, kind of think twice, but maybe not. Sometimes they say, I'd be depressed if I was that sick or that old. If you have lots of medical issues going on, the doctor might think, well, gee, he's got a right to be depressed. Maybe they have vague symptoms masked by illness. So no energy, but if they have COPD or diabetes, maybe they don't have the energy to get up and walk across the room and do all the things. If they're demented, they may not be able to tell you the story. So the bottom line is here, right at the end, denial, and it's a very commonly denied disorder in both the patient and the doctor. And if the doctor can say, well, I'm wondering if you might just be depressed, that's a good thing to think about. You might want to just ask your patient, gee, do you think you're depressed? This stuff is going on. So important to think about. What do you think about Rusty and Jake? They're sitting here and we're getting old, Jake. They have the cat who's the mailman. They don't feel like going to chase him. So I'm not sure. Is Rusty and Jake old, or are they depressed? So we don't know. Let's talk about risk factors for geriatric depression. There's a number of them. Psychosocial risk factors, retirement. And actually, when you get old, it's a big change of life. You've been doing things your entire life, and now at 65, your reward is you can retire. We're going to put you out to pasture. Even if you don't want to retire, we're going to retire you. And sometimes that's a big stressor. Bereavement, if you lose your mate. Do you have anybody to talk to anymore? And a big risk factor for depression. Loss of autonomy or independence. Loss of autonomy if you go to a nursing home, if you get sick, if your doctor says, I just don't think you should drive anymore. I'm really afraid of you out on the highways because, your eyes, you have that macular degeneration. You can't really see the car in front of you, or, with your arthritis, you can't really turn around and see in back of you. So I don't want you to drive anymore. Or I'm going to call the Department of Motor Vehicles and make sure you don't drive anymore. That's a loss of independence, and that can bring on depression or depressive symptoms. Economic difficulties, if one has been doing pretty well all their life and now you find that you're living within a fixed income. Kind of scary to think, well, gee, I'm going to have to dip into my savings to pay this medical bill, or the house needs a new roof on it. How am I going to get the money for that? Social isolation and loneliness. So if you have a real good friend that you go to coffee with once a week and that friend gets sick or passes away, you're lonely. You don't have anybody to be with. Medication risk factors. A lot of times we doctors put patients on medications that can bring on disease. Beta blockers, for one. If you're on propranolol, that's a lipid-soluble beta blocker, kind of an old beta blocker, and if you use that, you might bring on depression in your old patient. If you put them on atenolol or metoprolol, that might be a little bit better. These are not lipid-soluble, they're the kind of the newer ones, and they're the ones that we use more often right now. So, but beta blockers as a whole may bring on depression. Steroids, prednisone, if one has a COPD exacerbation, you bring them into the hospital, you're going to put them on H2 blockers. Tagamet is worse than Zantac. Prilosec doesn't have that same type of an effect, omeprazole. Benzodiazepine. So if you get sick, you come in the hospital, we're going to put you on steroids, we're going to give you an H2 blocker if you're in the ICU so you don't get ulcers. We're going to give you something to help you sleep. So we're going to really put you into depression. Disease risk factors. I want to talk about that for the next few slides. If you're older and you have a disease, even beyond what you might think the stress of that disease could be, that can bring on depression. Cardiovascular disease, high blood pressure, congestive heart failure, a heart attack. It's a big transition in life, and that can bring on depression. If you have a stroke, I have a slide that follows. We're going to talk a little bit more about stroke, but Alzheimer's disease can also bring on depression, or depression accompanies Alzheimer's disease. Cancer. You hear about paraneoplastic syndromes. If I have a certain kind of cancer, I'll also have other symptoms that will occur along with that. You might even think that depression is a paraneoplastic syndrome, because a lot of times it will accompany depression and cancers. And other conditions too. COPD, rheumatoid arthritis, deafness, chronic pain, renal disease, constipation. If you go to the psychiatrist for depression, he's probably not going to think, I wonder if you're constipated. Something to think about that. And also kind of think about what mass media does. I think it's Correctol. Is that the one where they say, I feel good, da-da-da-da-da-da-da? Well, those people aren't depressed. Those people don't have constipation. So just kind of think about that. Let's talk about the risk factor of dementia. Dementia and depression a lot of times overlap. In fact, one study says that 17 to 87% of demented people have depression. That's quite a wide range, and it's because it's very difficult to diagnose depression when one is demented. If they can't give a good history or say, gee doc, I really feel this way. But it's a consideration. Think about that. Depression may be an early sign of dementia. There's the article, the Dyer article that was in JAGS, the Journal of the American Geriatrics Society, says that one may start out depressed and then move on into dementia, move on into Alzheimer's disease. So kind of think that as well. And depression can decrease executive function. So if you're one who has Alzheimer's disease and you're depressed, you may not be able to do all those executive things that you should be able to do. Maybe not the checkbook, but even just going to the grocery store to pick up some milk requires a lot of executive function. Planning to go to the grocery store, getting transportation, getting there, finding the milk, taking it to the checkout, paying for it, going home is a lot of stuff. So if you're depressed, if you have a little bit of dementia, you may not be able to do that. Also, there's some research going on right here at University of Texas which says when you have patients who are demented, put them on an antidepressant. Put them on a little bit of Zoloft and see how they do. And a lot of times it helps them function a little bit better, brings them on up. Not so much treating depression, but trying to restore some of the brain chemistry. The risk factor of stroke is real important for a couple different reasons. Number one, the anatomic location and the time period. If one has an acute stroke in the left frontal region or the left basal ganglia, very often those patients become depressed in the acute period. They might get a little bit better as the time goes on. If you have it in the right frontal lobe or the right parietal region, sometimes those people do pretty good right away, but then after they've had a stroke for a week or so, they get really depressed. Frontal lobe a lot of times takes care, or that governs one's mood. So if you have any type of an insult to the frontal lobe, that can bring on depression. But it's not just such an anatomical location, it's also, your own personal history. If you have a stroke, you've been depressed in the past, very often you might get depressed again. Something important to think about. If you have fewer social supports, if you have more of a degree of impairment, or or if you have a family history of depression. All this stuff is very important to think about in patients who have had a stroke. Think about it early, and you may want to start an antidepressant or some type of a treatment a little bit earlier. The last line of this, they're 3.5 to 8 times more likely to die after their stroke or of a stroke. Very scary. Let's talk about the risk factor of elder abuse. There was a study that was done also by Dyer in the same journal of JAGS. They looked at patients who were abused, and they said they looked at what are their medical conditions that they had. High blood pressure, coronary disease, diabetes, congestive failure. None of those was associated with a higher risk for elder abuse. Depression was very high. You can see that the yellow is those who were abused or neglected. The green is more of their comparison group. So statistically significant for depression or dementia. So a big risk factor. Let's talk for a few minutes on how you can diagnose elder depression. Very easy, you can listen to them. There's no real diagnostic test for elder depression, but if you just listen to them, you can find out a lot. If you look at them too, if you see somebody who just kind of sits there and you ask them a question, oh gee, I don't really know. I mean, even their body language, if they slump down in their chair, they just aren't interactive, if they don't look at you, if there's no line of sight, think maybe depression on those. Functional ability, if they come with a family member and they say, well, up until 6 months ago, they were doing all this stuff. They were driving and going to play cards, and we were going out to dinner, and we were going to movies, and all of a sudden, he stopped doing all of that, and he just wants to sit around. That's a decrease in functional ability, and it's kind of a trend. And a lot of times people wonder, is that Alzheimer's disease? Do they have some type of a dementia? You can do a history and physical, and that's real important. The history, finding all this information, but also you want to rule out anything else that's going on. Is there thyroid disease going on? Are they anemic? Do they have cancer? Or any of the other things that we talked about? Do they have hypertension or rheumatoid arthritis? Anything that might suggest that there's something else medically going on. You want to rule that out. But if you have, then kind of think maybe they're depressed. And it's difficult to get a lot of information from one who is either demented or depressed because they may not want to volunteer that. But if you ask their family members or friends who might come to them to the appointment with them, or their caregiver, they might just tell you lots of stuff that makes it very sensible. There are some written diagnostic instruments for elder depression. The Beck Depression Inventory and the Hamilton Depression Scale, the HAM-D, very well-known instruments that can help pick out depression. The Savage Geriatric Depression Scale, however, is that one scale that really looks toward older people. So, and it's a 15-item instrument that you can hand to them and say, can you fill this out? Or you can ask someone in the office, can you just run the geriatric depression scale with them? I apologize for this next slide. It's microtype, but actually it tells a lot of information. And if you have a handout, it's very, very clearly printed on that. But these are some of the questions that the Savage Geriatric Depression Scale asks them. Some of them, do you often get bored? Are you in good spirits most of the time? Do you think it's wonderful to be alive now? And if they have more than 5 wrong answers, that says, think depression. And if they have more than 10, think treat for depression. That's really a very sensitive indicator. So as we talk about treating depression, when do you treat the depressions and how do you treat it? We doctors don't do a very good job of treating depression. Actually, we don't do a very good job of finding depression, but this slide shows a study that was done also in JAGS, also this year. They looked at 3 time periods, and these were the elders who, the yellow shows that these people were depressed, the green shows that they were significantly depressed, and in 1989, only about 10% of patients who were depressed got treatment. 91, we got a little bit better, but not that much. 93, we got better, but still only 25% of those who were significantly depressed were treated. Since then, since this time period though, Prozac and some of the other medications, the selective serotonin reuptake inhibitors have come out. So it makes it a little bit more kind to treat for depression. If we were using the old drugs back at that time, they may have had a reason why they didn't want to treat. The same study shows that when people at that time were treated, often they were not sufficiently treated. In 1989, most people, if they were treated for 30 days, just a minimum dose, just a little bit of a dose. A very small number of people were treated for 90 days, a little bit for the 30 days of the adequate dose, about 29%, but 90 days where they should have been, adequate dose, was less than 10%. 1991, it really seemed to get worse, and in 1993, got a little bit better. The pink column looks a little bit better. Elder depression is very difficult to treat from a number of different aspects. Number one, the patients just may not want to comply with the treatment. They may not say, well, gee, yeah, I guess I am depressed. I'm going to go ahead and take this medications. These medicines can be expensive, and if you're on a fixed income, you may not have enough money to buy the medications. If they cost 50 cents or $1 a pill, the question might be, do I want to take this medicine for depression or do I want to buy food? And that's a real concern out in the community. So it's real important. They may not start working right away. I have a few slides coming up that'll show you some of the individual medications, and often it takes several months for them really to take full effect. These medications have side effects. And again, we're going to talk about those in just a moment. And it's very easy for a patient to say, boy, I'm just not going to take this. I feel rotten. I feel worse from my antidepressant than I did from the depression. And if you're taking a lot of drugs, a lot of our patients take numerous drugs. And if you're taking a number of drugs, you can have an interaction between the two. So not very easy to treat. But when should you think about treating? Should you treat major depression only, or minor depression and major, or should you treat dysthymia? We know that if you treat major depression, that's very effective. It works. And it works in a number of different environments. If you're a primary care doc and you treat someone for major depression, if you can identify that, they're going to do better. If you're a mental health specialist and you treat them, they're going to do better. And if they're young or they're old, they're going to do better. It's not so clear-cut, though, with dysthymia or minor depression. When you're talking about dysthymia, this is an article in JAMA this year, just out toward the end of this year. And there was a test given to a number of patients who were dysthymic and who had minor depression. It's called the SF-36, and it's 36 different areas that they look at, and it's a degree of functionality. And they treated patients with dysthymia. They had high functioning, intermediate functioning, and low functioning patients, and they treated them with Paxil or with psychotherapy. Just let's talk to a counselor, let's do some behavior modification, let's do any one of the other very effective treatments for depression or for dysthymia. And they did the same thing for minor depression. They gave some of these folks Paxil, and they gave some of them psychotherapy. And they found out that where this achieved statistical significance was with high-functioning patients who were dysthymic. You can see on the slide there was about an improvement of about 6 points in the very first column, or patients with minor depression, sort of low-functioning patients who had either Paxil or psychotherapy. They did better with minor depression. So the bottom line is, we just don't know on dysthymia or minor depression, should you treat or shouldn't you? Some things you might want to think about is if they look like it would be convenient or you think they benefit from treatment, either with medication or psychotherapy, go ahead and treat. If you think, in your own judgment, that patients with dysthymia or minor depression should just be treated with watchful waiting, that's also okay. We just don't know, but it's important to just keep following that up. Every time you see them, say, how are you feeling? And if they extend into major depression, then just go ahead and treat. Lots of different ways to treat them. You can use biological therapy, you can pharmacotherapy, that's usually the one that comes to mind. I'm going to put you on an antidepressant. You can use ECT if they're really bad. You can use psychotherapy, and there's some other ways too, and we'll talk about those in a few minutes. But with pharmacotherapy, 60% of patients who have major depression get better. That's pretty good. Most antidepressants work pretty well, but they have a lot of different side effects, and it's good to custom tailor those side effects to the patient. Years ago, we had TCAs, tricyclic antidepressants, and we treated patients with those, Elavil or nortriptyline. And they worked pretty well. They blocked the reuptake of norepinephrine and serotonin. Well, we don't use them as first line anymore because they have so many side effects. They have sedation and urinary retention and dry mouth and blurred vision, constipation. We already saw constipation can bring on depression at some times in some patients. This can make it worse. Orthostasis, when they stand up. We still use Elavil and Pamelor, though, very effective medications to help someone sleep at night. Or if they have diabetic peripheral neuropathy, we'll give them 10 milligrams of Elavil at night, and it's very effective for diabetic peripheral neuropathy, for the post-herpetic neuralgia of shingles. So there's certainly a place in our treatment for them. Not so much with depression, though. MAO inhibitors, I'm just saying this for historical reasons, we don't use these at all anymore because of life-threatening problems that can occur. Dangerous side effects, certainly orthostasis, risk of fall, but if you eat some cheese that has tyramine in it while you're taking an MAO inhibitor, or drink some red wine that has certain preservatives or certain chemicals in it, you can get very sick. You can actually die from that. And there's a lot of interactions with many drugs. In fact, if someone is on an MAO inhibitor, we need a 2-week washout period before starting an SSRI. So we don't use it anymore. SSRIs, selective serotonin reuptake inhibitors, are our first-line treatment, and they work well. They block the reuptake of serotonin. They're effective. They're well tolerated. We can use them once a day. If you're going to give somebody Pamelor, nortriptyline, that's a 3-time-a-day medication. And that's a lot of stuff for somebody who might be depressed to take. If you can say, I'm going to get up in the morning and I'm going to take my blood pressure medicine and my antidepressant, good. Then you don't have to think about it anymore, and it's very easy to get those into your normal routine. The very first one that came out was Prozac, fluoxetine, and it worked well. And there's still a place for Prozac in the treatment of geriatric depression. A study came out about a year ago that said Prozac should be used. The FDA says it's really good. The medical community knows that there's other options, though. But Prozac works well. The concern, it does have some breakdown products, some metabolic byproducts that hang around for a while. The parent drug, fluoxetine, lasts for 3 days, and some of the breakdown products can last for 10 days. And you don't really want to change things. You start somebody on Prozac and you leave them alone for the first 30 days. If you have somebody who's young, you start them out on 20 milligrams a day. It's kind of easy to think about that. And then you can increase them. Increase them if they don't do better after a month or so. If you have somebody old, the thing to think about, the words are start low, go slow. Start low, start at a lower dose, 5 to 10 milligrams of Prozac, and kind of increase them to 20 to 40 milligrams as the maximum dose. So a little bit lower than what you'd normally think for a younger person. Zoloft is a very popular antidepressant for older people because it really works well. Short half-life, 25 hours, and there's a mildly acting metabolite, but look at this. It gets the steady state concentration in not 30 days, but 7 days. So they're going to be feeling better. They're going to get more of an effect from Zoloft in about 7 days. If you're young, start off a little higher. If you're old, 12.5 milligrams for a week and then increase to 25 milligrams. That usually works pretty well, and they have very fewer side effects. Big side effect of Zoloft, a lot of times people say, I've got a dry mouth, I have to drink a lot of water, or I get a little dizzy. And a lot of that is with all of the SSRIs, but they are so much better than the TCAs. SSRIs also, Paxil is a very good one. In fact, Paxil a lot of times is the first line. It's one of the things that we reach for, very common. Short half-life, 21 hours. No active metabolite, which is really desirable in older people. They don't have those breakdown products that they have to excrete over a longer period of time. The concern is, and so again, start low, start at about a half dose, and then titrate them up slowly to about 40 milligrams. The concern with Paxil, it's the most anticholinergic, so it has the dry mouth and the constipation and a little dizziness associated with it, but still in all, a very good medication. And if they can work through that, the dry mouth and the dizziness and the constipation, a lot of times that improves the longer they're on it, and it's very effective and it's very kind to them. Beyond SSRIs, there's a new class of medications called SNRIs, serotonin and norepinephrine reuptake inhibitors. Effexor XR is actually the long-acting form of Effexor, venlafaxine, works pretty well. It not only blocks the reuptake of serotonin, but also norepinephrine and a weak dopamine. So it just kind of helps brain chemistry a little bit better and has a very short half-life, The parent compound, the effects are not the long-acting, but the parent one is 3 to 5 hours and 9 to 12 hours with the active metabolites. The longer acting is a little bit longer than that, so you can still take it once in 24 hours. And again, start at a kind of a half dose, 37.5 milligrams, and slowly titrate up, see how they do. But the good thing about Effexor is it helps even within several days. It's not protein bound, so you don't have to think, well, I'm going to have to wait a month for you to feel better on this. You might even feel better in 3 days or 4 days or maybe even a week. And down at the bottom are some of the other side effects of that. If you have somebody who's really going downhill fast and you're really concerned, they're depressed, they're not eating, they're not drinking, they're just a mess, and we've got to get something taken care of right away, consider Ritalin. Methylphenidate, very good medication. This is the same stuff that they give to hyperactive kids, but in older people, a very low dose can often boost people on up, get them out of bed, get them moving within even a couple days. Start low again and go slow. Remember, Ritalin is a popular drug of abuse, so you might not want to give them a bottle of 60 Ritalin, but start them out really low and increase it as you need. The thing with Ritalin is if you give it to them, they may start feeling better right away, and then after a couple weeks, their antidepressant has really kicked in, and you can either taper or discontinue Ritalin and hopefully get them feeling a little bit better. Talk briefly about St. John's wort. Works, maybe is effective, but the concern is that in dosing of that. We don't just get St. John's wort, but along with the extract, we get hundreds of other compounds, and if they're already taking Zoloft and they take St. John's wort just to get a little bit more of a kick, they can get serotonin syndrome. So something real important. So if you have someone you think is taking St. John's wort, if you say, I'm going to put you on an antidepressant, tell them to stop that. Or if you know that they're taking both, it's a dangerous situation. Other ways to treat: counseling, psychotherapy, exercise, bright lights. If you're in a northern atmosphere where it's dark a lot of the times, think about bright light therapy. Just a word on ECT. Elderly are the largest group to receive that. It works well. And if you have someone who's very depressed, you may want to think ECT. How long do you treat? 6 months after the complete remission. So when they get better, when things are going well, if they have a setback, they get depressed, you say, I'm going to put you on an antidepressant. Continue to treat them even though they might look like they're doing better. And then when you get to at the end of 6 months, think, well, maybe it's time to take you off of that antidepressant. Don't just say stop taking it. Say, let's taper it down. We're going to take either one every other day or a half of a dose, and then we're going to taper you off. And just keep a close eye on them. See how they do. And if they have a recurrence, remember that it recurs. 50% after the first episode, 85% after the second, and 90% after the third. So what do you do if they have recurrent disease? Restart that same drug, same strength. Start them right back where they were, and it'll help. And then continue for a year after the resolution. And also consider other treatment modalities too. But you know, if we're talking about 80 to 90% recurrence, you may want to just say, probably would be better for us to just leave you on an antidepressant lifelong or for a real long time. And that's the end of my prepared remarks. I certainly would be happy to take any questions that you might have.
I have 3 questions.
Yes.
First of all, you mentioned that they can stay on their antidepressants if they have a need for it, they can stay on for the rest of their lives. Have they done any studies on how long Prozac has been given to one individual?
That's an excellent.
Having any
Certainly, that's an excellent question. Prozac is a very controversial medication, and I can't quote any studies that would say Prozac specifically, but I can tell you that just watching the treatments of different medications, different depressed patients on large group studies, it's fairly effective. But that's a very good question about safety. You also have to watch people and what other medical conditions do you develop. And if they develop other medical conditions, it's important to use antidepressants in the context of other issues. If one causes dizziness and they start having falls, you may want to think, do I want this person on this medication that might increase the risk for falls?
Also, I want to ask you, is it still true, you mentioned that the elderly have the highest suicide rate in the United States, is that correct?
That's correct.
Is it still true that, okay, is it still all true that most of this occurs in single white males, that they're the highest, the ones that have the highest suicide rate?
Absolutely. Males over the age of 80, the 80 to 85 group have the highest risk of suicide, and they have the most lethal methods. So if you have someone who you think might be suicidal, maybe rather than starting an antidepressant that might work in a month or so, you might say, let's sit down and talk to you right now, and maybe you need to come into the hospital, or maybe we need to get you to a safe place, or if you're alone, maybe we need to get somebody moved in with you for a little bit, or short-term hospitalization, or bring you into a SNF, or something like that, or a group home, or just as long as they're not alone and you help them out.
I have two more.
Yes, ma'am.
On the diazepines, if they're on diazepine, I know they're supposed to be given for short periods rather than over a long term. Did you say they also cause depression? Benzodiazepines?
Benzos can also be a risk factor for depression. It's one of the medications. It sort of slows them on down, and if one is on long-term benzos, they certainly can. It can decrease their executive function and just their overall performance.
Okay. My last question is, have you done any studies on the increase of depression in women in other internationally, on other ethnic groups? Like, is there a higher percentage in Hispanic women, African Americans? Are they doing studies worldwide on which groups have the highest depression?
That's an excellent question, and I can't quote you any information on that. I'm sure studies are being done on that, really to target different groups, target different age groups, target different ethnic groups, and look for different risk factors. But it's real important, and that is very good. Thank you for that question.
Let me ask you, when you talk
Yes.
about the three types of depression, major, minor, and dysthymia, but dysthymia, they actually have to have it every day for 2 years.
Right.
So why does that make that less than a minor depression?
That's a great question. Dysthymia really is a very difficult thing to diagnose. You've been grumpy. Is that kind of the way that you've been? A lot of times when we think about dysthymia, we think about how has someone been long term? Have they been sort of grumpy, or have they had these things for a long term, looking in retrospect? Not so much of a, gee, I'm feeling this way, I've been feeling like this for a month. Well, if you come back in 23 months and you still feel this way, we're going to do some treatment, or we may just do watchful waiting. So a lot of that is, how have you been? If you take a history and physical and they say, well, I've even for 2 years or 5 years, or this is sort of my lifestyle, that I've been sort of grumpy like this, you may want to think about some kind of a treatment. But again, when we take a look at the treatments, we see that for dysthymia, they may or may not be that effective. So, but you're absolutely right. There's also a big overlap between dysthymia, between the dysthymic symptoms and minor depression. So it's very reasonable just to skip dysthymia and think more of minor depression.
Did you say dysthymia occurs more in men
Yes.
than women? Okay.
Mm-hmm. Any other questions? If you think of any other questions, or if you didn't get a handout, I certainly would encourage you, please send me an email, and I'd be happy to send you any information or clear up anything else that might not be clear, or if you have specific patients you want to discuss. If that's cut off, it's Krueger, Kruger, at medmail, medmail.com. Thank you very much. Great.
And we didn't have any more questions? Gosh, I'm really surprised. This is such a big area.
I just think one interesting facet of this, or like a caveat of this, is like widowers, especially widowers.
Uh-huh.
I was doing some
Oh,
studies
yeah.
on widowers. There's not much information on widows. There's information. You go to widowers, and there's hardly any information.
There are
on
very
them.
few widowers, is what.
Yeah,
Right.
yeah, that way it's increasing.
That's
though.
right.
It's changing.
That's right.
It's
Oh, yeah.
It's
changing.
changing, but up to now. it
Yeah,
hasn't
and so there needs to be a lot more research on that. There's not
Oh, yeah.
much. You can go to flip to a book, and if you want to look at widowers, you can't even, it's hard to even find information on it.
Well, the thing that I didn't say, I really didn't have time to say, but what do you do about patients who have a major stressor in their life, like if they lose a spouse and something happens and you're the doc, you want to do something, and you say, your spouse died 2 weeks ago, you're understandably distraught. Do you put them on an antidepressant? Or do you put them on something? Do you give them sleeping pills or something like that? And a lot of that depends on your own personal interaction with the patient. If you know them well, you say, gee, you're really not eating or not doing all the things that you should do. It's reasonable to think about antidepressant. It's also reasonable to think, let's just wait and see how your bereavement is doing. But a prolonged grief reaction is about 6 months. If after 6 months they're in bad shape, clearly put them on something, or if they haven't come back.
Death usually ensues after a year. They usually say, isn't that normal, 6 to 12 months?
Right.
Time period.
Often.
Often.
Thank you very much.
Would you recommend Zoloft versus Prozac, or is there a one better, lesser, or?
I generally like Zoloft a little bit better than Prozac. Prozac, since it has so many metabolites and they last such a long time, if you say to someone, I think the reason that you're not feeling well is because of a drug interaction, because of Prozac, and you stop the Prozac, they're still going to have those metabolites in their circulation for weeks. So you can't just stop it and say, well, you'll probably feel better tomorrow. So with Zoloft, still have that a little bit, but not as much.
Not as much. Okay, great.
I have one more question from El Paso.
Yes.
You mentioned Effexor?
Yes.
You say what classification of drug is that?
It's called an SNRI. It's an SSRI, the selective serotonin reuptake inhibitor, plus a bonus of norepinephrine inhibitor and a little bit of a weak dopamine reuptake inhibitor. So it keeps a lot of the neurotransmitters in the synapse for a little longer, helps restore some of the balance.
Is it very expensive?
I can't tell you. SSRIs and SNRIs are fairly expensive overall, but I can't tell you exactly how much it is. I would say probably under $1 a pill, which is expensive. Thank you.
What goes up must come down. Spinning wheel got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel spin.